Good evening and welcome to this segment of Medical Jargon. I'm your host, Gregory E. Smith, Administrative Director of the Prompt Care Clinic located in Pembroke, North Carolina. On today's segment, we'll be discussing colon cancer screening, treatment modalities, and interventional options. My guest joining in the discussion, Dr. Harvey Allen, board-certified gastroenterologist from the Southeastern Health Digestive Center located in Lumberton, North Carolina. Dr. Allen, good evening and welcome.
Good evening. Thank you for having me.
Oh, pleasure indeed. Now, this month is Colon Cancer Awareness Month.
Yes.
Now, a lot of my patients and certainly my viewers are very interested in that topic, and given its incidence, stands to reason
Yes.
that they would be, in fact, quite curious. So, if you would, enlighten us.
Well, again, thank you for having me. And this is a very appropriate time to have it. Like you said, it is the colon cancer screening month, and all the cancer awareness bodies are having colon cancer awareness and trying to increase awareness in our communities. Colon cancer is the second most common cancer death in America.
Wow, that's huge.
So you're talking almost 140,000 new cases a year. And it's a preventable disease. And so that's
Indeed.
why it's a topic that people really want to start becoming more aware and get screened. It's the fourth most common cancer in America, and like I said, it's preventable just by going to your physician and asking to be checked and screened.
Indeed. Yeah, a lot of patients in my office, and particularly at the age of 50 on, I began to have those discussions about colon cancer screening, and obviously you want to get a very thorough family history. And so I use different screening modalities, and by all means share with me the best course, if you will, for screening.
Well, like you said, everybody should be screened at age 50. And they say, why? Did we just pick that out of the hat? And no, 95% of most of the cancers come after age of 50. So that's the sort of the magic age. There is a racial predilection that in African Americans now, the AGA and all the bodies, because of the increased ferocity and the cancer in African Americans is more prevalent, they recommend screening at age 45.
Oh, I see.
So
Okay.
there are a lot of different modalities to screen, and you need to discuss that with your primary care, which one you'd like.
Indeed.
There are 5 or 6 now different types of screening, and do you want me to just go through each
Please.
one or
Absolutely.
elaborate?
My viewers are quite interested, and I've had actually in the last week, I've had 4 patients in, certainly over the age of 50, who have in fact family history. And so in my discussions with them, I certainly had to inform them that it's a great idea to look at preventive medicine, because what I do, and certainly my 20 years of being in the field practicing, and I'm certainly certain that you do the same thing in your office, you really emphasize the importance on preventative medicine.
Oh, absolutely.
It's huge. It's very important. But go ahead.
Well, the sort of the gold standard, we'll go for the best first, is called colonoscopy. And that is where they take a tube and look the entire colon and check for it. The reason it's the gold standard is that you can do therapeutic, where you can actually take out the cancer or take out the precancerous lesions, and you look at it directly. It's not a projection, like an x-ray would be more of a projection.
Indeed.
Well, now the fiber optics are so just excellent now that we actually look the entire colon and magnify it, and it can look at each inch of the colon for cancer.
Sure.
And we can take it out. The test takes about 15 to 20 minutes. Most people don't remember anything. You're sedated, and they're very, very minimal risks. There are some risks, and that's what you need to speak with your doctor about, the risk, but they're very minimal. And the best thing, and for me, I've had it myself, so I know, I'm not just talking.
I probably should get scheduled with you as
yes.
well. Yes. Have one, but go right ahead.
Well, for you, whenever you like. But the best thing about it is that once you screen, you don't have to have it for 10 years. And so that's the new recommendation. So you're seeing a procedure that can save your life. It's almost pain-free. They're very low risk, but a definite small risk. And you don't have to have anything for 10 years. So it's a really win-win.
If I may, let me ask you this. What if during this screening or diagnostic colonoscopy, you actually find something sort of, let's say, a suspicious polyp? My understanding, and by all means correct me if I'm mistaken, that if you find something, you biopsy it.
Yes.
And if in fact it's positive, obviously you're going to resect those polyps.
Correct.
But my understanding is that the study should be repeated within 6 to 12 months. So you tell me.
Well, you opened up a large can of worms. We can sit here for hours.
Sure.
The National Polyp Study at the VA about 10 to 20 years ago came out and said that majority of colon cancer can be resolved, or the vast majority, 90%, if you take these precancerous lesions out. And most time the precancerous lesions are called small polyps. And we burn these polyps out. And once you burn them out, you don't have to really get checked until actually 3 years. Now that's why colonoscopy is so good, is that it is therapeutic. Now the other screening modalities don't do that. Like barium enema, you will take a projection of the x-ray and say, well, this looks like it's fine. But that's an x-ray and it misses about 10 to 15% of cancer, so that's sort of number 2 on the list. Then there's a shorter procedure called a flexible sigmoidoscopy, and which actually also looks, but it doesn't look at the entire colon. So those are and lastly, that have been approved is a digital rectal exam where they check hemocults for blood. So now, I don't know if you want to go over, there are some sort of research protocol things that are not approved but are showing excellent promise. There is a stool DNA that comes in about 40 to 50% that can detect cancer, but it's not well received, and it is expensive. But for people that don't want any risk or not able to undergo the procedure, and now there's a CT colography, which was developed at Wake Forest and I think in Brooklyn, and together the radiology, they take a projection, also a 3D modality CAT scan, which is excellent. And they're sort of research, but they're becoming now moving into sort of one of the standard options.
I know that in our office with these patients, I typically will do the initial first-line screening of digital rectal examination and stool guaiac. Now, obviously, we know that some patients who certainly complain of rectal bleeding, the important thing for us to ascertain is the color of the blood in the stool.
Absolutely.
Because we know that certainly bright red blood makes us smile because we're looking at either fissure, fistula, or
absolutely.
or hemorrhoids. And so the important thing to certainly inform our audience on and our viewers is if the stool is black. I mean, we certainly shouldn't have melanoma black stools or white stool steatorrhea, unless certainly with the black stools, the patient is on iron supplementation or Pepto-Bismol, magnesium, one of those things.
Oh, you're good.
So thank you. So in the absence of those things, we know we should not have those black stools. Absolutely. And then abnormal weight loss. So if you would kind of elaborate more on the symptoms, if you will, some of the stuff I just touched on, that patients will know to pay attention to.
Well, when you, colon cancer symptoms, majority of patients have no symptoms. And so that's one of the major things, is that you feel fine, you look fine, you walking around, and you come up with cancer and shorten your life expectancy just because you didn't get screened. So majority of colon cancers, people have no symptoms. Now, some of the symptoms, like you said, are rectal bleeding, abdominal pain, nausea, vomiting, weight loss, change in caliber of your stools,
Sure, indeed.
things like black stools. All of those things are sort of very things that, I need to get checked immediately.
Indeed, indeed. Well, this has been a wonderful set, and certainly very informative for our viewers. Very important for them to have this information. And so if one of the things we want to make sure of, at least in my office, and I'm sure that most offices do the same thing, abnormal weight loss makes us a bit suspicious.
Oh my God,
I've lost
yes.
25 pounds over the last week and a half. I don't know why. I'm not trying to lose weight. In the last 3 weeks I've lost 20 pounds. I don't know why. And so I think it's very important to really go over those particular signs and even the symptoms.
Absolutely.
So that our viewers have a pretty good baseline of information that would sort of key them into saying, hey, I need to go in and get checked out. Not just the fact that I'm age 50 plus, you see. So very, very important. So great session. Thanks again for stopping by.
You're welcome. Thanks for having me.
Oh, absolutely. Pleasure indeed. Now, for further information on colon cancer screening, treatment modalities, and interventional options, call 910-738-3103. Again, I'd like to thank my guest, Dr. Harvey Allen of the Southeastern Digestive Center in Lumberton, North Carolina. Now, join me on the next show of Medical Jargon, where my guest will be Dr. Santos Augustine, board-certified gastroenterologist, and the discussion will be on dyspepsia and gastrointestinal motility disorders. Also, following that, Dr. Nwosu, cardiology, and we'll discuss hypertension. We'll see you until then. Eat well, eat healthy, live well, and don't forget to schedule your next preventative medicine office visit.